It's a pleasure to introduce today's plenary session. So UiO is a WHO Collaborating Center for Innovation and Implementation Research in Health Information Systems Strengthening. And the tangible results of this partnership have been the development of health data content for DHIS2, which we generally disseminate through the WHO metadata packages. Some of you may have heard of these. So those who really know DHIS2, you know that out of the box, it's an empty shell. So you have to define all of the metadata that's in there for all of the different health programs that you need to capture and collect and analyze data for. So we've been working with WHO for the last several years to define a kind of gold standard DHIS2 configuration for health metadata. And we've been working towards this goal forever in mind with an integrated in-country HMIS. So a health management information system that has harmonized metadata and can capture all of this core data across different health programs. So this DHIS2 health content, we think it's even more than the metadata packages themselves. These can be installed onto national DHIS2 instances, but we really see this as an extension of WHO's work on developing health facility data toolkit and several other tools that are in their SCORE framework that Anh will also introduce to you guys. So the partnership, WHO is technology agnostic, but DHIS2 is a platform used by more than 70 countries. So together we know that we can leverage this presence in so many countries to disseminate these global standards and to support the WHO's curriculum on analysis and data use. And further push ourselves as well to facilitate uptake with end user training materials and with demo databases and system design guides that help us to disseminate good practices in how to do DHIS2 design. But also we learn from real world implementations, and we learn from all of the countries who have been out there implementing and designing and integrating their systems. So in the parallel sessions today, you'll hear from a broad swath of our community of practice around how they've been using DHIS2 to meet health program goals for HIV, TB, RMNCH, immunization, other areas. But in this session, we are very welcome our representatives. So Dr. Anh Chu from the WHO headquarters, as well as representatives from the Lao PDR Ministry of Health, the Palestinian National Institute for Public Health, and the Rwanda Ministry of Health to share their perspectives on the journey towards strengthening integrated HMIS and adopting these global standards. So without further ado, I'm very pleased to introduce my colleague Anh from the Division of Data Analytics and Delivery for Impact. She's based in Geneva, and she's the primary focal point at WHOQ for our UiO collaboration, which is continuing to grow. So she has a long history with DHIS2 implementation. She has been a champion for promoting the platform as a way to disseminate standards, but she also spent many years working in the Lao PDR WHO country office. So she is a steadfast supporter of making sure that we keep our global products and collaboration focused on meeting the needs of countries and helping countries to support their goals. So Anh, I will hand it over to you.
Good afternoon, everybody. Very nice to be back to be with the team, and I'm very sorry that we will not be able to see everybody in person. Can you hear me well? Because we had some problem with audio earlier.
We can hear you well, thanks.
Okay, so thanks, Rebecca, for the introductions, and hello to everybody. It's very strange to talk to supposed to be a very familiar faces, and we don't see anybody here, and which makes me a little bit more nervous. So today I'm talking on behalf of the Division of Data Analytic and Delivery for Impacts, which is the new division in WHO. I have lots of people ask me the question, what is DDI doing? So we thought it would be a very good idea of taking this opportunity to give a very brief introductions of what DDI is doing and where we are in the collaboration and partnership with the University of Oslo, and work on the strengthening of the health information system, but most of all is to see how we're going to do together to support the country to overcome a lot of challenges by trying to reach the overall common goal of the universal health coverage and the health-related sustainable development goal. So I am just trying to see how I'm going to do this. So let me start with this. I think on Monday, when Dr. Samira Asma, our director of the division, gave the opening remark, and one of her first things to say was that the high level that WHO, together with all the countries, state member, to come up with the goal, which is the triple billions. And out of that, it means the entire world together, we're trying to have a 1 billion people to be more benefiting from universal health coverage, another 1 billion to be enjoying better health and well-being, and 1 more billion is to be more protected from the health emergencies. And that is even more relevant now with the ongoing pandemic, which affects everybody in every corner of the world. And that would also be something that we have to consider. And I think that is something was very relevant also on the presentation yesterday, when you see how different countries put or work together to try to control this pandemic. And that will also affect the efforts of all the countries put together to achieve these very ambitious goals. So the DDI was that is the short name for the Division of Data Analytic and Delivery for Impact. It is it was established aiming at supporting the organization to support the country in see how best we can trying to prioritize and support to strengthen the services in health sector, but then through the evidence base, which is this is why where the data coming in, and it's why we are focused on in our divisions. There are 3 main strategies. Number 1 is to see how we can better measure to support the monitoring of the progress, how we're going to support the country to focus on what is the best way to prioritize to reach the results, and how we're going to measure the impact, how we're going to support in terms of building capacity, in terms of coordination, get the governance side right, and get all the concerned parties work together so that the country will achieve the targets that contribute to the 1 billion or triple billions. For us, what we're doing is that we have 4 key areas that building into this strategy. Number 1 is to set the standards and also provide use of the data available to get the estimate right so that the country can set up the goals that contribute to the 3 billion goals. Also, we can only do that if the country have a robust and comprehensive and good health information system. And through that is how we're going to work together, how the data is going to circulate and use and collect it, and all of that through the data governance and exchange, so that everybody will see where they are and how to get to the next steps, which lead to the stock taking to see, that is all different milestones of measurement of the country. One of the latest result of products that was published recently by the division is the score, which is for the first time, it's a very comprehensive tools that represent all the different components that to build a comprehensive and strong health information system. And then the report of that will be released by the end of this year. And this technical package that was launched last month has offered more than 90 different tools and technical guidance that help the country to see how best to strengthen the health information system. And DHIS2 was mentioned there in several areas. Out of that, they all focus a lot on is how to strengthen the data collection, the analysis, and also use of it to strengthen the routine health information system. Also, one of the new features, and it's being working on with within our division, is the World Health Data Hub, which is the end-to-end data single repository that will help country to send the data regardless of different formats. But the main point is that they go in one place, but then it can be presented through different portals. So one is for the country to use. So the country share the data, but also have they can also see the data through their own portal. And out of that, what is the achievement and the status of the 3 billion will be reflected there. There will be a one-stop portal for all data linked to health that's sent to WHO. And then there will be another portal that for you to go and do the analysis that is needed for your own use or for the country or for the program. And then one of the work that's been going on is the collection of the data catalogs. And based on that, we are trying to set the standards. And DHIS2 will be one of those group of data, metadata standards that's going to be in this data catalog. The other new feature is the mapping, the GIS. We just recently established the GIS Center that aim at 2 purposes. One is to work and support the Ministry of Health through our country offices to strengthen and use of the mapping for the country boundaries, but also for the health facility, and be it as a part of the analysis to make better presentations of and visualization for the outcome of the health sectors. And secondly is to build a global database linked to the boundaries and the health facilities so that it can be served as a base for any country who wanted to start, to use mapping and location of health facility in the health information system. So having said that, so what would be the work of DHIS and the University of Oslo with the WHO as part of the collaboration? Rebecca had mentioned earlier in the opening speech, and that was the work we have been doing in the last 3 or 4 years in terms of trying to build a standard for the data collections, for the data analysis, and the presentation of it through a set of dashboard standards that help country to visualize, to analyze the data better, but also for the cross analysis and comparisons, and also for WHO, it's a very good step to start for standardize the data, but also for all different programs to work together. And why we have to do that? The latest World Health Statistic report showed that there are lots of countries that don't have enough capacity at the moment and don't have the available data to help them to monitor the universal health coverage and the SDGs. So one of the core points and linked to that is we need to help the country to monitor, which is the routine health information systems. And DHIS2 has been part of WHO to strengthen these 3 areas. Number 1 is to set the standard through the standard digital packages and to make sure that the data are harmonized and collected. Secondly is to help them in terms of strengthen the analysis, link that with different other data, which you will see later in the country implementation, to see how does it fit in and help the country to monitor the 3 billion targets linked with the other data sources. And in the future, how we term that together and be part of the end-to-end data repository through the integration of different platforms, different programs, and also link with different interoperability with the GIS, with the ICD-11, with the logistics system, and with the survey to make sure that the data are transparent and visible and accessible wherever the users are. And the result is we have 39 countries have implemented this. with the support mostly at the moment from Global Fund and Gavi, which you have heard from the presentation yesterday. And there are more and more partners also wanted to support this and to see the benefits of having one single integrated routine health information platform that share across different programs, different partners, and can be used across the entire country. And so far we have this many products, and the latest one was COVID, which is developed in a very interesting way, which I hope you heard of it yesterday. I was really, really impressed how it was developed and made into available through a cohesive and cooperative way by many different players in the communities, and how it was rolled out so fast in such a short time. We have more in the pipeline and moving from aggregated reporting into a case-based with trackers. But also one of the things that coming up a lot recently is the community health information system as one of the core points for the primary health care, which is an essential part of the universal health coverage. And how do we work together? We have the WHO mostly, but also UNICEF and other, the technical partner contribute in the technical guidance for the agnostic health data collection and analysis standards. And we have the DHIS2 community help in terms of making it into a digital data package that can be implemented in the countries and adapted in the countries, so that it not just meet the needs of WHO, but more importantly, it also meet the needs of the country data requirements. And then I think also one very interesting feature is the network with the health data collaborative, where all the partners work together and support the country implementations. How do we do it together? We have come up with a very simple cycle, which go through development, testing, implementation, lesson learned, and then go back to the improvement. And then we start with WHO or technical agency, and then from the second phase, we work hand in hand with the University of Oslo, aiming at strengthening this package and make it as user-friendly as possible. So this is what we do. We work together. We're trying to put country at first, make sure that it is usable, it is useful, it is supporting the implementation, but the capacity building in the country. It has a feedback loop so that we always learn from our doing. And then the improvement and strengthening of that is a continuing process. So just a simple key message here. We need to have a clear guidance on how we use the data, what data is needed, putting the country at first for the user perspective. Then we need to make sure that there is an environment that supports the implementation and the use of data, strengthening the data quality, the governance of data, make sure that there is a privacy, there is confidentiality and security for whoever use our system. And then, and last but not least, is that, it doesn't matter how strong the software is. Our WHO and our DHIS2 colleagues also need a very clear standards, need a very good communications, and a unified common guidance that we work together so that the country can have the same message and they can make the best out of this without lots of confusions, which we come up sometimes. And the need to work together to strengthen the capacity in the country. So that was a concept. And for the next, it was how it works in the reality. And I'm really looking forward to listening to how our friends in Palestine, Laos, and Rwanda are making this into reality. Thank you.
Thank you, Anh. And now I'm pleased to introduce Khadija Abu Kader from the Palestinian National Institute of Public Health.
Hi, Rebecca. Hello, everybody. Nice to join you this session and hope next year to be face-to-face, inshallah. I will share my screen so you can see my presentation. I will be presenting the Palestinian experience on behalf of the Palestinian National Institute of Public Health. We are the Palestinian Institute of Public Health. We are one of the WHO projects that have been endorsed by the Palestinian government and the president to be an independent governmental entity and evidence-driven institute that aim to improve the health and the well-being of the general public in Palestine. We are working closely with the Palestinian Ministry of Health, our colleagues at the Norwegian Institute of Public Health, and other partners from University of Oslo, the DHIS2 HISP and community. Okay. So UiO, since its establishment, has been working heavily with the stakeholders to strengthening the essential public health function and the health system in Palestine through providing accurate and reliable data and evidence-based information. Creating an integrated and sustainable HIS that collects all information, health information in one system, enabling easy access and better overview of health within the country is our vision and would be an appropriate tool to reach the goal. So, our condition in Palestine regarding the HIS before our working on this field, we have unfortunately a limited functioning HIS, where there was a health information system in hospitals, which started in 2009 and currently is running in almost all governmental hospitals. And only 4 health directorates out of 13 having this HIS, in addition to only 4 clinics out of more than 400 clinics also having the HIS. Unfortunately, we can notice that this HIS was failed to be scaled up or to be sustained, in addition to the lack of proper technological solution and the resources constraint. So, at 2017, we started our experience with the DHIS in Palestine with the national implementation for a customized tracker of the interactive checklist and decision support system, and this has been implemented in close collaboration with the Norwegian Institute of Public Health and University of Oslo. Starting from this point, we have noticed at the UiO and Ministry of Health that DHIS2 is will be a good HIS tool and software for the Palestinian context, as being able to be customized for our need and for our health system needs. So the UiO has invested heavily the capacity building of Ministry of Health and UiO staff until we succeed to establish a national country team with a member from both UiO and Ministry of Health that have been with wide range of specialties and capacity. UiO tried to provide every learning opportunity for the team to master the skills and the knowledge that needed to maintain and to develop the DHIS2 program in Palestine. And actually, the team were able, with the remote support, to develop, to customize the first HMIS aggregated system for most of the primary healthcare report and statistics. And this is only was the beginning. Then a tracker program, which is patient-based tracker for the case-based surveillance and for mammography also was another achievement for this team. The big achievement was within system that we were working on to integrate the NCD and to have a unified patient record where all primary health care services have been integrated in one electronic record, and with avoiding the verticals program to track patients from being registered on birth registry till death registry. Even with the outbreak of COVID, which started in Palestine at March 2020, the team managed successfully, and we are proud to say that in a short notice to develop a COVID surveillance package according to Ministry of Health needs and WHO packages and standard definition for the COVID positive and confirmed cases. So, at this slide, you can see the graph that shows the current ongoing e-registries and computerized program in Ministry of Health Primary Healthcare Clinic. You can see on one of the side, we have the MCH e-registry, which is customized tracker, version 2.29. You can see at the end of the graph also, we have the HMIS, and in the middle you can see the standard tracker that have been built by the national team. All of them are in 2.30 and they are in the process to be updated 2.32. Unfortunately, we noticed that there are a limited data program. So I'll move for the next slide, which is show the ideal vision for the primary healthcare e-health application. we are looking forward to have this graph on the ground, where would like to have an ideal version where all registries have been interacting with each other, and there will be like a master registries to be synchronized with all other trackers, where essential enabler data will be exchanged in unified format. So we can notice that we are planning to have a 3 master registry, and actually we will succeed to have at least 2 of them, the facility registry that contain all facility in the primary healthcare, and we have the HISP they are ready, and now we are working very well on doing the client registry. All these standard tracker, and there will be like an data exchange and integration with these registries in order to be able also to interact on to do integration with outside Ministry of Health HMIS and health information systems such as DRR, the PCBS, and the other health system and non-health system in Palestine. Okay, so how we were working during our work with the main partner, the Ministry of Health and other partner. We were able to approach Ministry of Health in different ways. The first approach and the first mechanism that we were heavily investing in is the building the national capacity in DHIS2 that would enhance the developed HIS and to ensure the sustainability. So ministry and other partners would feel the sense of being always being able to be supported. They will be able to maintain the developed HIS, and they will never left behind. It's very important so that they can be committed to the developed HIS and other programs. Other approach that we use with the Ministry of Health is the implementation phases. We never went for program in one time. We depend on the gradual phases in implementation, where we do sometimes piloting, then go if the program was working well on the real and on the ground, we go for the national scale up. This is very important as this will facilitate the change management process and the adaptation of the Ministry of Health and the systems user to the new technology and to the system. Another important point that we will rely on during our working with the Ministry of Health to strengthen their health system is the clear requirement, where we usually develop for any developed program, we prepare a clear requirement and we share it with the related technical units, starting from the minister, from the deputy to the technical unit, and even sometimes with the end user, to make sure that these requirements are matching with their needs, with a satisfying flow of work. And this is very important as it would enhance the ownership and implementation. Also, the open and active communication, listening to the partner, especially Ministry of Health needs, being frankly and honest on what the DHIS2 and what developed system can do and what cannot do. It's very important. This would help to have a trust relationship, and this would also help us in providing a continuous feedback for the Ministry of Health and for the partner to make sure that we are working on the same ground and we are doing what they are expecting. So we will not be surprised, or the Ministry of Health to be surprised with an expectation that did not come to the mind of the developer or so looking to the factor that's contribute
I'll give you just a 2-minute warning. Thanks.
Yes, okay. The contribute to the success of the work. In addition to what I have mentioned, I would like to highlight the e-health strategy initiative that is going now in Palestine, and it helps us to have a commitment from the Ministry of Health to be able to implement the different health systems. I would like to go to the last slide in my presentation, which is the future perspective. We continue our work with the Ministry of Health to strengthening their system. We are planning to focus more on the stability and further growth for the DHIS2 platform. We are planning to include more health services that have not been part of the health system till now, such as the mental health services and the school health. And a major issue also we are focusing on is the integration with other non-governmental health sector. we have started with the Ministry of Women's Affairs. We succeed to have National Observatory for the Gender-Based Violence, and we are planning to move for other organizations such as Ministry of Education, Ministry of Interior. And the part of Oslo and the HISP for better outcome and for better strengthening for the health system. I will stop here, Rebecca and other colleagues. And I have to thank here the PNIDH team. Without their dedicated work, none of this would be achieved. And special thanks for our colleagues from Oslo, from Norwegian Institute of Public Health, and we will not forget our colleagues from HISP for their generous support and cooperation. Thank you.
Thank you so much, Khadija, for sharing all of these hard-earned lessons learned. And I do hope that the strong foundation of the HMIS lets you reach to your ideal. So we'll keep learning from you in the years to come. Dr. Chansali and our Lao PDR team, the floor is yours. I'm sorry, I should introduce, I'm sorry, Dr. Chansali Pomavang. He's the Deputy Director General for the Department of Planning and Cooperation at the Lao PDR Ministry of Health. So welcome, Dr. Chansali.
Dr. Chansali say already.
I think you have to share your screen to slides. PowerPoint. Share them. Okay, can you hear us?
We can.
Okay, so I just would like to start our PowerPoint. Where did that go? Why? Okay, so this is the first presentation that the topic that we are going to cover during these 10 minutes, mainly talking about what we have done and what the future we are going to do. And I just begin by the overall what we have done in the past so far. The DHIS2 has been already started since 2015, and 2017 is already become the coordination of the integration platform to the whole country. So far we already trained more than 1,000 staff for the training staff on not only for data entry but also for using of the system, managing the system, everything. And so far only 14 key health programs has already been integrated into the DHIS2 system, so that we can see later on. And more than 1,200 health facilities, meaning including the central hospital and provincial district and health center, already using the data for enter data into the system. And so far we check the automatic report. So far already 90% reporting completed. Oh, so far very quick. The second thing is now we already integrated many programs into the system. What we call more than about 40 programs has already integrated into the system. So we apply three functions of the DHIS2, both including aggregate, event capture, and tracker. Because so we can see here some program has already on using already aggregate and event capture. Some program already still mainly event capture, and so far we already have one program like logistic management information system have already interoperability with the DHIS2, and we still have about 3 programs that in the future will integrate into the system, mainly for the health insurance, the hospital information system or EMR, also the human resource information system will be later on integrated into the system, but mainly we cover all the key programs that required for the government check and tracking indicator. So this is the main integrated into the system in Laos. So what so far ongoing the system that we are doing now? So for DHIS2 being used not only for collection of the number or call rate, we also extend it to the quality of service, meaning that we use the system to to track the quality of service at the hospital. We are now already customize the quality scorecard into the tablet so that the health center can check, the center level can check the quality of service of the health center and health facility. We also include also clinical variant, meaning that how the health staff perform using the DHIS2 model to check the quality of the staff who have performed the treatment of the disease in the hospital. We also improving the quality of data. Aside from we have a normal system already in place like mark-min or validation rule. We also have the quality checklist on tablet to capture data on this, mainly for the EPI data, right? Also, we have the system comparison between the survey data and routine data, the integration of the UNICEF global platform for DHIS2. We also using the system to monitor the disbursement link indicator, which is funded by Global Fund and the World Bank, to track the indicator that later on it can link to the payment. Without this DHIS2, the World Bank Global Fund cannot proceed the program, because even based on that to verify whether the system and the actual implementation is included. We also use the indicator to monitor the quality of the quality of care of nutrition, financial management, information system, and also other programs like the HIV, TB, and the EPI service. So we also integrate data from other sectors to the main HISP-UiO, because we also integrate of the climate data into the system. We can link between two information to monitor to inform the decision maker where it's needed to help, and also the data can be shared with the Ministry of Home Affairs, mainly on the mortality of the children mortality, the maternal mortality, so that we already have agreement. Any information from this, so we can share with them, and any information that they have from the system from the MOHA can share with us. So we also have the innovative approach to strengthening event-based surveillance. So we have used the surveillance function of the DHIS2 to develop capture information from hotline call, disease surveillance. We also strengthening the capture data from community service for strengthening of surveillance system. We also expanded not only the facility-based information, also extended to the community-based information. We are now collecting information that is not collected from the routine information like water supply, and also the family planning into detail, and also the health insurance. So mostly we from the community-based, we got the real population count, meaning the real number of target population that we used to calculate the main indicator. So also we, as we said, we use we customize the tool like the WHO data quality assessment tool, immunization data analysis tool, and so also the dashboard for the COVID-19, which is really useful information. So what we already adopting global standard of integration for HISP-UiO. The first thing, the Lao PDR adopt the standard WHO tools such as the data quality tool, immunization analysis tool. We also have used the adopt the customized standard packet of COVID-19, as I mentioned before. So during the COVID-19, only our system can provide interesting information for the COVID-19 tracking. We also use the standard report for generate. This is specific system, for example, for TB, HIV, malaria, which is very standard, so that they can report not only to the country but also report internationally to the WHO, to other things, because of the standard, because of the reporting already is standard. Also, we are working also with the national digital health guidelines standard to ensure the interoperability. We also continued, we got the continued support from the WHO to the Lao team. We also got support from the University of Oslo, the health information system in Vietnam also stand by anytime that we need them. They just provide the support, technical support for us. So as I said, that we are working with the partner. We are not only Ministry of Health alone, but also working with different partners like Global Fund, World Bank, ADB, Luxembourg, and many partners putting funding together, not only the funding itself, but also technically putting together. We also have regular partner coordination meeting, talking about health information system. We update, we regularly review the system, review the how people are using the system to monitor the indicator, how people are using, what is challenging, what is a benefit from that. We holding the regular meeting. We also have the one system, one door system, that all information, all the design or development of the form should be gone through our DHIS2 team. We also have the one integrated plan. We need the plan including all the partners in the end, including also government, the different partners like World Bank, ADB, Global Fund. We know the all activity. We also use DIY-based funding to sustain resource, because the DIY disbursement link indicator provide very sustainable funding to stimulate the health staff to continue working on the quality of the health information system, and also part of the regional and global HISP strengthening initiative.
Dr. Chansuli, I'll give you 2 minutes warning.
Yes. This is the last PowerPoint. So aside from success, we have also the challenging. For example, first is of course about the use of information. Anyway, we have no matter we have good quality of data, but people didn't use it is not good. So we also many people still not understand the whole concept. Many people use the system, but some people use the system. They tell us whatever they want to do, but some system cannot functioning to provide what they need. Also, the data quality needs to be strengthening. We need to strengthening the ownership of the people who are using the system. We also so the key lesson learned, we have to, first of all, we have to have a very strong leadership. And also we have to have the strategy to guide to involve all the partners to put to investment into the system and to make the system more functioning and sustainability. So this is in the future we will continue to working with the hospital information to integrate into the system, and also interoperability with the other system that's not in the system yet. This is my last PowerPoint. So thank you, and any questions you can have.
Thank you so much, Dr. Chansuli. I think it's just really impressive for all of us to see how much you have achieved by having a common plan and a common investment framework, and now being able to push into some really innovative areas with the M-Supply integration and working across sectors. So it's my pleasure to introduce our last speaker. It's Andrew Muhir from the Rwanda Ministry of Health. Andrew, if you would like to share your screen.
Thank you, Rebecca. And okay, good. So my presentation will much more focus on the Rwanda's approach to strengthen HMIS and adoption of WHO standards without taking much time. We currently have one integrated system in Rwanda that collects all clinical data from all health facilities. So this is the background. We mostly before 2011, we had the system that was an offline system, but in 2011, we managed to move from the offline system to a web-based system. So the main aim of moving was the fact that the system was really not easy to maintain, and it was a little bit complicated. So in 2011, we reviewed our tools. You can see it on my PowerPoint. We reviewed all our tools and harmonized our reporting form, and we developed also SOPs to ensure that the new system has all needed materials that standardize the data management across the facilities. Then in 2012, we launched the web-based system. 2013, we worked around indicator manuals and ensuring that everything, the definition is everything is well defined. Then 2014, we implemented the ETB, which was the first case-based system to be implemented in Rwanda. Then we continued 2018 and 19, where we've been working with WHO to implement the data quality tools, and then AP tracker. So these are the standardized documents that we developed in data management. We have SOPs, we have data collection tools, we have indicator reference manual. Then these are the packages that we already have in place now. We have program routine clinical reports that are reported directly from the health facilities. Then we have case-based like ETB, AP tracker, and the MCCOD, that medical certification cause of death. All of these are WHO packages. Then we have annual reports, daily flash report that helps the high levels from the ministry to take actions, real-time action. We have disease surveillance. Then we have performance-based financing. Then COVID-19, as I presented yesterday. Then the data quality mechanism, because all of above cannot be really useful when we don't have the mechanism of data quality. Like many other countries, we work with the DP, which is the development partners, to ensure that the data we collect is of good quality. So we have what we call integrated supportive supervision that brings together multidisciplinary teams, including partners, and also I would like to appreciate the contribution of WHO in this process. So all of them, they come together, then they take data from DHIS2, then they go down to check if whatever is in DHIS2 is the same as what we have in the system or what we have in the source of data. So this one also contributes a lot in terms of data quality and also confident when we are taking a decision on our data. So we have decentralized monthly data validation also that also contribute a lot on this. This is an example of the monthly data validation meetings. You can see that health workers on monthly basis, they meet and they check the data before it's reported in HMIS. But again, we also have another meeting that they do to discuss on their indicators and the health, their indicators and whether they are moving up or down. So this is the data use monthly meeting that I was talking about. When they discuss, it's always chaired by the head of the hospital. Remember that at the hospital, it has the catchment area of the health centers. So they discuss and they try to come up with interventions, but all of interventions are based on the data. So they present directly from DHIS2. Then they take actions based on what data says from their catchment area. I always give an example of an increase in malaria that we had a specific period of time. Then there was an intervention that the government says those people from this category, they have to be subsidized. Then the community workers also have to consider adult for treatment. But all of that was from the DHIS2. So how are we using these packages? Because we already have the framework of data management in place, but what we did in 2019 was like changing most of our tools to ensure that we institutionalize or we accommodate the new tools, because most of the time we promote information use, but when we don't have robust tools to ensure that people are able to visualize data, they're able to visualize errors and outliers. So that's where we really we installed with MO and UiO and WHO. We joined the efforts and we managed to train our people, and we installed the WHO data quality tool. And this tool was also institutionalized because we changed our SOP when we shared a link our SOP is version 2019. So it really accommodates the use of data quality tool. And this one has really contributed a lot because it's very easy for you to track the outliers during the data checking and data review meetings. So we also have the program level dashboards. You can see that on my dashboard there, we have TB and TB notifications and deliveries. Most of these dashboards are from packages that we really installed, and we tried to customize them based on the program needs and facility needs. So for sustainability, we always collaborate with our partners, but also we've been really working closely with WHO to ensure that our teams are also trained with collaboration with WHO, with University of Oslo. We managed to have a pool of experts in the country to ensure that whatever we are doing is not based on one person, but is based on the pool of people across the country, so that whenever time we need, we'll always have expert people around to support the system. So we are now introducing the use of e-learning as part of mitigating the COVID situation, but also some funding. You know that training is expensive. So we are now using e-learning to train our people. We have managed to train everyone on the data quality, including the WHO data quality app. So now we are also adding other content to train them online. So the contribution of these packages and dashboards and DHIS2 is really wide, but I wanted just to highlight a few of them. There's policy and strategy decisions, HISP program planning, more resource management, capacity building, and others. So future plans, because even though I'm presenting that we have these tools, we are not where we want. We are still need to join efforts with our partners and everyone to ensure that we promote the information use at facility level and district level, availing data use tools to users, e.g. WHO packages, capacity building to all users. These are the areas of focus. I didn't want it to write the bullet points. You can see it from the system, the favorite views. You can see that obviously our system is telling us, the DHIS2 is telling us that most of the people are using pivot table and charts. So we need to put much efforts on the dashboards. We need to put much efforts on other analytical objects like maps and others. So this is the link to our tools that I've been presenting, SOPs, annual statistical booklet, and others. Thank you. This is the end of my presentation. Better information, better decision, and better health. So for any questions, please post it in the committee of practice. Thank you.
Thank you, Andrew. That was amazing. And I particularly like the slide on data use and being able to leverage that framework for data management. I also think we're pretty excited to see what you all do in terms of e-learning for COVID. We have maybe 3 minutes, so maybe can only take one question. There was a question about how to actually support data use. So once databases are set up in countries and they have more of the standards, how do we ensure that the data gets used? And I think or if another presenter would like to answer that question, but then we'll move everything else to the community of practice, which I have posted in the chat.
Okay. Hi, Arthur. Thanks for the questions. I think if you understand it correctly, it's about, about the data lake concept. If that's the case, the whole point is that the whole data lake concept is to ease the way the countries share the data, and then it should be made available and accessible to all the country to use it. But of course, to show it on the internet, it doesn't mean that it's going to be used. And then that is, in the name of the division, there is the Department of Delivery of Impact, where they are actually doing lots of estimates and then work with the country to come up with the targets for different countries. And then every 3 months, they take a stock takes of, how far they have gone, and then use these portals as a way of showing how far and where the country goes, and then trying to work with them to make use of the data and then collect the data again. So it's in a circle, but it's what's more important, and it will need further strengthening and collaborative effort to support the country, is to set up a proper data governance with focus on the data use, to strengthen the data quality, and also to build the capacity. And I think that is where the DHIS2 standards with the integrated platform plays a very, very important role, because it already has a lot of engagement from different programs, and then have more interest in that. So we can talk more about this, but I'm very much aware of the time, and please feel free to contact me anytime. Over.
So thank you, Anh, and also thank you very much, Khadija, Dr. Chansali, and to Andrew for sharing with us your country experiences. We look forward to following your continued progress over the years. And at this point, we will stop the recording and get started for the next session. Thank you all very much.